I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. I wanted to dialogue with you briefly here as it relates to new guidelines that were just published by the American College of Gastroenterology on Barrett's esophagus surveillance and diagnosis. Let me begin by saying Barrett's esophagus is a common problem, and certainly reflux disease even more so. So we get a lot of questions about this, don't we? Esophageal adenocarcinoma is rising at a rate of nearly six-fold over the last 2 decades. The Barrett's guidelines that are just published are an update from 2003, now 2008 with the update. Let me just point out what's previously been established, what's reiterated in this guideline, and what's new. So let's begin with what's a reiteration. First, Barrett's esophagus is the #1 risk factor for adenocarcinoma of the esophagus. The guidelines are quick to point out that surveillance is still controversial, and screening in average risk patients without reflux symptoms is very controversial and not recommended. Dysplasia is certainly something that warrants an expert pathologist. So if you have a dysplasia patient, a patient with dysplasia, this needs to be confirmed by an expert pathologist. The diagnosis of Barrett's is not one that we establish clinically, it's by histology, so specialized columnar metaplasia, again, a reiterated message for this guideline. And certainly if there's anything focal, this should be referred to a center that has endoscopic mucosal resection capabilities. So 2003 and 2008 guidelines both agree. Now what's new? Well, the key issue is high-grade dysplasia. Previously, this is a fast-track ticket to a surgeon. The guidelines at present in 2008 say no longer the case. Certainly endoscopic mucosal intervention by thermal therapies, intensive surveillance, or surgery should all be viewed as options. No longer a fast ticket to a surgeon. This may be a wake-up call for some of our surgeons. Secondly, there are a variety of things that we can do with the endoscope through white light imaging, but enhancers of imaging with now narrowband imaging, confocal imaging, chromoendoscopy, spectrofluorescence, a variety of things that are nice, but the guidelines say not quite ready for prime time as necessary. So we're seeing a lot of things emerging, but not necessarily prime time yet. And the same as it deals with prediction of the future. Wouldn't it be nice if we could tell our patients with Barrett's, you have a risk for cancer by X%. Biomarkers have been something that have been very, very extensively researched, but the guidelines say nice, promising, but not quite ready for a blanket indication for all patients with Barrett's. And the intervention by medications, first by chemoprevention strategies with COX-2 inhibitors, again, not ready for prime time. Maybe some data to support it, but the guidelines are quick to point out not evidence-based. And also the same with proton pump inhibitors. There is data that suggests that patients presenting with dysplasia have a lower odds ratio for being off a PPI, meaning a PPI may be somewhat preventative, but the guidelines say not necessary at present to support this as a chemoprevention strategy. You should be treating patients with Barrett's based on their reflux symptoms. So a lot is new, a lot is reiteration of strong messages previously established, but I'd like you to join in your dialogue here by select this and correspond with your peers. Begin a blog, engage, and find out what everybody else is thinking. I'm Dr. David Johnson. I'd like to thank you for being here, and I look forward to our next interaction on this type of dialogue. Thank you.